Thank you very much, everybody. And really
Okay.
appreciate to have this opportunity having together. So my name is Xiaolin Wei. I'm a professor in the Dalla School of Public Health. Uh, and I just, Xiaoyun, maybe you can just introduce yourself.
Thank you. Thank you. Good morning, good evening, everyone, colleagues and friends. Welcome to join the workshop on primary care workshop. This is jointly held by Dalla School of Public Health, University of Toronto, and China Center for Health Development Studies, Peking University. We hope this joint workshop panel discussion will help us to bring some new inspirations and for future research and collaboration in the area of primary healthcare quality. So my name is Xiaoyun Liu. I'm Deputy Director of China Center for Health Development Studies from Peking University. So we are very happy today. So about 2 months ago, Professor Xiaolin Liu from University of Toronto and we came up with this idea that we need to have some panel discussion in this important topic. Finally, this come true in the end. So this very short panel discussion will last about 1.5 hours. We've invited 6 speakers, important speakers from both Canadian side and Chinese side. So followed by a half an hour panel discussion. So if you have any question during the presentation, please write your question and comments in the chat box, or keep your question to the end of the presentation. We can have some. Professor Xiaolin Liu will chair the final panel discussion part. And because we only have 1.5 hour session, we do not arrange a tea break within the workshop. So without further ado, I would like to invite Professor Meng, the former Dean of School of Public Health, Executive Director of China Center for Health Development Studies from Peking University, to give us some welcome remarks. Professor Meng.
Thank you, Xiaoyun. Dear Professor Laporte, dear speakers and participants, good morning and good evening. On behalf of the co-host of this workshop, China Center for Health Development Studies, Peking University, I would welcome all of you to participate in this important event. And many thanks to Professor Wei from the Lana School of Public Health, University of Toronto, and Prof Liu from Peking University for your effort in making this workshop possible. 3 years ago, I and my colleagues went to Canada for a study tour, and where we were impressed so deeply by the well-performed primary care system. We learned a lot from the UT colleagues through a wonderful workshop. Quality of primary care is a critical topic, not only for China and Canada, but for the world. Over the past decade, primary care has been well developed in China with the government effort, but many challenges remain to be addressed, especially that in quality of primary care. So I'm sure lectures from the excellent speakers today would stimulate thinking on how quality of care, primary care could be truly improved. I'm looking forward to a successful workshop. Thank you.
Thank you, Professor Meng. Professor Meng strongly support us to hold this workshop and encourage all our faculty, teachers, and students to join the discussion. So today, from this side, many of the participants are our postgraduate students and our colleagues in this area. Thank you again. So next, we will invite Professor Audrey Laporte, a professor in health economics and the director of Institute of Health Policy Management and Evaluation at Lana School of Public Health, University of Toronto. Professor Laporte.
Thank you so much. Thank you, Professor Meng. Thank you to Professors Wei and Liu for bringing us together today. On behalf of the Institute and the Dalla School of Public Health at the University of Toronto, I want to express my pleasure and gratitude for the opportunity to come together with distinguished colleagues from the China Center for Health Development Studies, Peking University. We all understand that primary care is a cornerstone of healthcare systems around the world. It is with our people from their very earliest years of life and is there to support and care for them to the very ends of their lives. It touches on all other care sectors, such as hospitals and home care and long-term care. So insights and improvements in primary care, we understand, can have far-reaching implications for the health and well-being of our populations, as well as the performance of the health systems overall. And we've all learned a great deal about the relative strengths and weaknesses of our health systems during COVID. And that is why it is such a special opportunity for us to come together today to learn from each other about what we can do better so that we're better prepared and we can support our primary healthcare systems as they face what we all expect will be a number of very challenging years to come. So again, I thank you all for coming together and for sharing your insights and your knowledge with us. And with that, I thank you, and I'll turn things over to Professor Walter Wochis from the Institute of Health Policy Management and Evaluation. Thank you.
Thank you, Professor Laporte. Thank you very much. I understand from Xiaolin, you give us very strong support in organizing this workshop. Now I will invite Professor Walter Wochis to give us a presentation on the changes in care of diabetes in Ontario during COVID-19. Professor Wochis, thank you.
Thank
Walter,
you
please.
very much. I appreciate it. And I was here 3 years ago, and I appreciate seeing familiar faces today. So I remember very well some of the faces I'm seeing today. And it's an honor and a pleasure to continue this conversation. Well, I don't have a lot of time, so I'm going to jump right into a few slides that I prepared that I can share to show you and demonstrate, I think, what we're seeing as we start to understand what's happening with chronic disease care during the pandemic. So this is some preliminary work for around diabetes management. I think you can see a full screen presentation here, hopefully so. So I'll give you just a moment of context, and then I need to describe, I don't know whether you remember, but I'll need to describe the primary care models in Ontario. We have a number of different models of primary care. And then I won't spend much time on the methodology, but just so you understand what we're doing and show you some of the results that we found. So first off is this idea of why diabetes and why primary care. So first off, diabetes management in Ontario has been an important area for improvement. And many reports have identified gaps in primary care for diabetes over past decades. And during COVID-19, today we're coming together to think and talk about coming out of this pandemic, well, living in this pandemic. Many primary care offices shifted to a virtual or telephone care and were closed to in-person visits. Laboratories were open, but people may have been afraid to go out for testing, and testing is a big part of diabetes management. However, I'll note, and this will become later when you see these results, that ophthalmology and optometry were more available as these services require in-person assessment. It's very difficult to do that over a telephone. And in Ontario, I'm going to talk about primary care models, and I'm going to call these models of care. And they range from solo physicians, mostly working in a fee-for-service environment with unattached or attached patients, to another extreme where we have very much interprofessional team-based care. And we want to know, does this make a difference to diabetes care? Okay, so, first off, diabetes management is important to prevent both short and long-term complications, as well as in the importance for care for people with other health conditions. So let me bring specifically the COVID-19 issues. And there's some data that early on struck me as really supporting the importance of diabetes management. And so this was one of the very first trials out on MedRVX on Open Safely from the UK, where they looked at factors associated with severe outcomes and hospital deaths. And I'm going to also highlight SARS being similar. So to motivate this, this study was of 17 million people in primary care, looking at those individuals who were admitted to hospital with COVID and what were the risk factors for having severe outcome of an ICU admission or death. And so the first off is in-hospital mortality. And you see here, obviously age, the reference category here is being under 50. I'm highlighting here some of the highest adjusted risk factors in a multivariate model. So odds ratios of mortality being 2 if you are 60 to 70, going up to 12 times if you are aged 80 or above. We saw these results elsewhere. If you were in the most socially deprived quintile, you also had a raised risk. They're 1.75. And then they also had a whole list of chronic conditions. I think all of us are familiar with seeing that organ transplant patients were at a very high risk, those with malignancies. And then what struck me in this long list of conditions is that the third one was uncontrolled diabetes. And then you see that being the third most important risk factor for causing death or being related to death, controlling for many others. This made me think back to some results I remember seeing back when SARS was true in Toronto in 2003. And so this is from a 2004 study of the people who were admitted to ICU or died among 144 of the first patients in Toronto. And this is proportion without, these are raw hazard results here of not having a poor income. So you want to remain up at the top of this. So you see no comorbid disease. Those people fared the best. And then if you had a comorbid disease other than diabetes, it's sort of a flat level risk around 0.7. And if you had diabetes alone, odds were you were going to be admitted to ICU or died. And if you had diabetes and any other comorbid condition, you see that those outcomes were quite tragic. And so it's not that diabetes management in and of itself is always important, but it's diabetes when we're trying to manage something else really is a complicating factor. So I'm just going to leave that in your minds as we continue to think about how did we manage diabetes during the pandemic. So my question is, how well was diabetes managed in primary care during the first year of the COVID pandemic? I will focus first on screening and testing, HbA1c, LDL, and retinopathy eye exams. I think we're all familiar with these. These are global guideline-based care. And then I'm also going to ask about whether diabetes management varied according to the primary care model. And finally, did management and outcomes vary according to socioeconomic status? We're very interested in understanding more about equity. Certainly, many of us knew about equity issues prior to the pandemic. They were raised in the general public's awareness during the pandemic. And here I'm also going to include hospitalizations as a marker outcome. So I'm going to start with the results in text form, and then I'll go through some diagrams so you can see, or some graphs that demonstrate these. So first off, diabetes screening for HbA1c, cholesterol, and retinopathy declined during the COVID pandemic. It declined between 5% and 13% year over year, and it was consistent for patients regardless of the primary care model that they were a part of. And it was also consistent for patients at different socioeconomic status groups. We also looked to see whether the actual results of the tests changed, and did diabetes control change? Well, actually here we see more of a positive story where diabetes control did not change much overall, although we did see that missed tests were up, and so we lose a little bit of sight on those, on the diabetes management. But when we look at it carefully, more of the missed tests were among people who had fairly well-controlled diabetes prior to the pandemic. And there was a little bit of variation by primary care models and a moderate gradient in diabetes control by socioeconomic status. We found that diabetes hospitalizations for short or long-term complications did not change much overall, but keeping in mind there's a very strong gradient in these hospitalizations by socioeconomic status that we continue to live with. So those are the highlights, and I'm going to put up some graphs now. So these were the testing results in 2019 and 2020. So up to March of 2020 is the dark blue bars. And then starting in April of 2020, carrying through to the next year, are the light sort of turquoise blue bars showing. So here you see that the testing, these are the testing levels, they're down across all. And then the far right says, were you current in all three? So we see that they're down. We also see that, quite frankly, in Ontario, we don't do very well. Many people are not compliant with their testing. Even prior to the pandemic, only 35% of all diabetics were compliant with all of their testing results. This is more of a complicated graph because it shows all the different primary care models. So whether people were on their own, so not rostered, meaning they didn't have an attached primary care physician. Then we had whether they were rostered, but that physician didn't have a capitated. They just saw patients and they're paid each time they see them, across to becoming more involved with interprofessional teams. That health team is the interprofessional team. So you see, in HbA1c testing, those teams do better than people who are just seeing a solo doc. LDL is a little bit of a mix. Eye exams, retinopathy, they seem to have that pattern again. And then all three is a more muted pattern where actually it seems everybody is having trouble getting in to see all tests. So by primary care model, we do see some patterns with HbA1c and retinopathy, but LDL is a little less clear. These were the screening rates according to material deprivation. So we actually see that irrespective of your material deprivation, we do a pretty good job in Ontario of making sure that everybody gets the screening. There's a mild gradient, but really not very strong at all. Again, just showing that everybody's missing out on some tests. But this is a good news that we have equitable access to testing across material deprivation. I'm not showing here the incidence rates of diabetes, but we do know that incidence varies by socioeconomic status. What about diabetes control? So here we're showing whether people, this is the HbA1c level. So if we didn't have a test, they're in the far left. And then if your HbA1c mostly controlled, less than 7, you see that's a pretty constant number. Between 7 and 8.5, pretty constant. And again, greater than 8.5. So what we're seeing here is that we did not see a big difference in the level of control among patients. And if you look at the no test, you can't quite see it on these graphs, but more no tests are showing up in that well-controlled category, as I mentioned. Can't show every result on these graphs. When we looked at it by primary care model, we also see here that there's not a lot of difference. There's a little bit of a difference in that some of the groups where we see less control are those dark blue lines on the left. And that's the people who don't have a regular physician to go to. They're not rostered. And so they tend to do worse than most of the other groups. Again, that sort of points out they also were the ones that miss tests the most often. So attachment to a primary care physician in Ontario is important in making sure that you can be compliant with your testing. Someone is looking out after you. And this is, again, now these are control numbers by socioeconomic status. So if you look over to the far right, which is where I'll draw your eyes on this one, you'll see that the people who have the most difficulty with control are those people in the areas of highest deprivation or lowest socioeconomic status. So in actual diabetes control, we do see a little bit of a gradient where it's more difficult for people to control if they are living in areas. This is an area level measure, not an individual level measure, ecological measure, but it does capture, I think, some of the constraints around people and some of their issues. So these are short-term hospitalizations on the left and long-term hospitalizations on the right, according to primary care model. I don't really know what to make of these, except to say, obviously on the far left, being unattached to a primary care physician leads to the worst outcomes in all cases. But actually, I'm a little surprised to see that the family health teams, the team-based models, also have relatively high levels of hospitalization in both short-term and particularly long-term complications of diabetes. So here our teams are not providing superior care management and keeping people well enough that they're avoiding these long-term complications. I think that's an insight for us, particularly here in Ontario. And I think I'm going to pretty well end off here, which is just to show that this material deprivation, which is the socioeconomic status measure here shows that, clearly there's a strong gradient in long-term and short-term complications for diabetes patients where management of these individuals is not as well controlled. They're being hospitalized at much higher rates, in fact, if they are living in neighborhoods with low socioeconomic status. So we're trying to bring an equity lens into pretty well everything we do. Some of the points, highlighting again, diabetes management is a challenge and a concern in Ontario. During COVID-19, many patients reduced adherence to screening for HbA1c or LDL. And we think that has a lot to do with their encounters with primary care, maybe not being as much on top or staying up current with their visits, to a lesser extent retinopathy, and that may be due to differences in in-person office availability, and possibly incentives for ophthalmology and optometry to be bringing patients in for income. There are also socioeconomic differences in diabetes control, and suggesting that testing of important biomarkers is not sufficient in and of itself to mitigate differences in patients' ability to control diabetes across socioeconomic groups. So I'll pause there. That was a pretty quick flash in the pan of diabetes management during COVID-19 in Ontario. But I think we do see some variability. Having a primary care physician to be attached to is important, and we do need to be thinking about socioeconomic status as we manage diabetes.
Thank you. Thank you, Professor Walters, for your presentation. Some very key findings on the diabetes control during the COVID-19 the pandemic. Because of the time constraint, I would suggest all the participants to keep your question, post your question in the chat box, or keep the question to the end of the panel discussion. So next, thank you again. So next, we'll invite Dr. Jeremy Viard, Senior Health Specialist from the World Bank. Dr. Viard has deep expertise in the quality of care area. The title of his presentation will be Determinants and Measurement of High-Performing Primary Healthcare System in Low and Middle Income Countries. Dr. Viard.
Thank you very much, Professor. It's a pleasure to be here with you. I apologize, I've lost my voice a little bit. We're in winter here in South America, south of the equator, but I'll try to do my best to go briefly through the presentation. So I'm just going to start by sharing my screen here. Great. And just to make sure that you can see it, yes. Very good. So I'm in presentation mode now, and sorry, I'm just going to start here. So what I'm going to try to do in the next 10 minutes is to tell you a little bit about the way the World Bank views the centrality and importance of investing in primary healthcare systems to strengthen health systems, achieve universal health coverage, and at the same time improve the resilience of health systems in the face of future pandemics. Our starting point, and I'm taking here some data that we released in 2018 about an international ranking of countries based on human capital and distance to frontier. You see that Singapore is leading the way in this synthetic index that we developed on human capital that really looks at the next generation. And we're looking at the ability of those countries to, keep the next generation healthy and at the same time achieve optimal educational outcomes. And what we see here is that for many of the countries around the world, there are gaps, and that those gaps actually translate very clearly in missed opportunities for further inclusive economic growth. So in a country such as China, and you see where it's positioned, that will translate in a loss of economic growth in GDP of about 1% a year, which you can imagine over a generation makes a huge difference. Obviously, it's critical. Investment in people is central to for countries to be able to compete in the future. And there's a lot that can be done to strengthen, human capital systems. And we're thinking about, social protection systems. We're talking about educational outcomes for all and we're talking about universal health coverage that delivers better outcomes. And so the point that we make here is that as part of the core set of strategies that countries should invest in to achieve optimal human capital outcomes and be able to compete in digital economies, they should be investing, in high-performing primary healthcare, which is key to build up and preserve human capital over the life cycle. Let me start with a couple of graphs. That's work that we did at the research department at the World Bank, making the point that, not only do we need, primary healthcare in theory, we need good primary healthcare in practice, and there are large gaps in quality of care. Some of those gaps, are due to lack of knowledge of providers, but also at times, gaps in practice. And, even when providers have knowledge, doesn't mean necessarily that they will put this knowledge to work. So we see here in many countries, the inability of primary healthcare providers to diagnose accurately, carry out their work in adherence to clinical guidelines, and we see the gaps in clinical management for very simple intervention. What's very interesting is that in several countries, what we see is that when we observe primary healthcare professionals who work the same day in public and private practice, because they have dual practice, we see that depending on the set of incentives that they're faced with in the public sector and in the private sector, the level of completion with clinical practice guidelines is actually dramatically different. And that's, sort of no-do gap that is, critically important to keep into consideration. So in 2016, the World Bank was commissioned by the Ministry of Finance of China to undertake a study on how to deepen healthcare reform and really get, in the context of aging and hospital centrism in China, how to get a more central role for integrated care systems and primary healthcare, at the center of it. And the conclusion of the study, it's a very large study with many accompanying case studies, is that there were really 8 elements that should be taken into consideration. The first one being that primary healthcare should be the first point of contact, that multidisciplinary care teams should be put in place and functional, that care should be better integrated both horizontally and vertically, that technology and information systems, should help, improve consistent delivery of high quality primary healthcare. Then we insisted on the importance of clinical pathways and dual referral systems, the importance of measurement standards and feedback loops so that systems can learn and keep on evolving. And finally, the importance of certification and accreditation processes. Further, I worked with colleague Asaf Biton at Harvard University to conceptualize the key elements of strong primary healthcare systems. And as you see, we developed this schematic about the 5 S, 5 M's, and 5 C's, starting with the 5 C's on the right, which are the core functions of high-quality primary healthcare: our first contact, accessibility, continuity, comprehensiveness, coordination, and centeredness, person-centeredness. That obviously, to achieve that, you need to have inputs, and that's what we call the 5 S's, and the resources of strong primary healthcare are space, systems, staff, stuff, which is really, medication and all that is required to deliver care. And finally, surveillance as a function for better population health systems. But obviously, to do that, you also need to have management systems in place and a number of attributes to the way you organize and deliver the care. And for that, we have these 5 M's, which are multidisciplinary care teams, measurement, management, monitoring, and ongoing motivation of staff based on ongoing feedback. Last year, the World Bank, in the middle of the pandemic, released a new study on primary healthcare, where we talked about shifts and priorities for reimagining primary healthcare, following, the COVID-19 pandemic. So those four structural shifts are pretty simple and consistent with what I just said, that really to go from low quality to high quality care for all, from fragmentation to integration and person-centeredness, from inequity to fairness and accountability, and from fragility to resilience. The three priorities to do that are: number one, to adopt a multidisciplinary team-based approach; number two, reforming healthcare workforces; and finally, reforming financing so that there will be sufficient resources and incentives to deliver high-quality primary healthcare. Measurement is critical. We don't have a lot of time to go through it, but I have led for 4 years a global initiative called the Primary Healthcare Performance Initiative at the World Bank, working together with the Gates Foundation, WHO, UNICEF, and other organizations. And what we've tried to do is to work around the world to improve performance measurement. And you see that we look at it from 4 different angles: performance being in the center in terms of access, quality, and coverage, but capacity and financing being very strong determinants, governance inputs, population health and facility management, and finally, equity being a cross-cutting dimension of performance measurement. A couple of words about innovation. When you think about delivery models, you should consider all aspects related to innovation. That's certainly something we've seen accelerate dramatically during the pandemic. We can think about, telemedicine and alternative delivery methods. What I want to show very quickly is a bit of a conceptualization that we've put together at the World Bank in trying to classify innovation by types: organizational, governance, data, technological, financing, and care pathways. And we try to group them and classify them in a bit of a different way. And what I'm trying to say here is that it's really critical that innovation reaches the front lines, and especially the most vulnerable. And that's very often what does not happen. So instead of starting with top-down models, what this model is proposing is really to try to start at family and community level and try to expand different innovation models and integrate them in a way that learning can take place. And all of those elements are represented in this diagram. So let me just conclude very, very quickly. Health system change is complicated and hard, but it's possible. What is required is to find points of leverage and keeping transformation messages simple. High-performing primary healthcare is critical to human capital growth and preservation. That's what we've seen during the pandemic. And that's why, a new flagship report that we're putting forward is going to be focused on resilience. We think that primary healthcare, beyond, providing, preventive and ongoing care is also actually critical in terms of surveillance and response to epidemics and pandemics, and it has to play a more central role. Global knowledge is stronger, but execution is hard, and that requires a deliberate approach to focus on the front lines where the patients meet the system and to ignite demand. And that means also empowering patients with information so that they can demand better care, effective access, and care that is really centered on their needs. I will stop here, and thank you very much for your attention.
Thank you very much, Dr. Beard, for your presentation from a global perspective on the primary healthcare performance. Especially pleased to say your World Bank comments on China's primary healthcare suggestion of primary health development. Thank you very much. And next, we'll invite Professor Xiaolin, who's a professor at the Institute of Health Policy Management. Professor Ali.
Thank you very much for this kind invitation to participate in this exciting workshop. I'm really pleased to have a chance to present some work that relates to primary care, drawing on some research that we have underway in Canada. So the title of my talk is meant to be provocative and maybe something to think about while we're all presenting, is that whether there are some missed opportunities in primary care to do better, to take to achieve better outcomes, more equitable and high quality care in the health system. And so we'll take that lens in looking at two studies that I'll share some high level findings of in this short presentation today. So to start with, the first study aims to compile learnings, a bit drawing on international experiences and promising practice with the adaptations and innovations in primary care for a particular subset of the population that is extremely vulnerable in terms of complexity and challenging needs, and that's people experiencing homelessness. And that's a wide variety and diversity of people who may go in and out of precarious and unstable housing, maybe living on the streets, in shelters, young and old, and a diverse population, and yet united in its complexity and challenges that primary care face. And so to briefly summarize this complex and major public health issue, I've just put a few data points on this slide, really underlining that Canada faces a major challenge with homelessness in terms of absolute numbers, but also in some of the health statistics around the high prevalence of mental health issues and very high prevalence of chronic health conditions, and then the stark inequality in life expectancy between people who are experiencing homelessness and those who are not, with the life expectancy gap 47 years for people experiencing homelessness compared to over 77 years. So we know that this is a complex problem, and primary care has a unique opportunity to better serve, to better meet the needs of this population and help them to navigate through the system, but also to manage their chronic conditions in the community. And so our aim was to really understand some of the promising features of primary care adaptations, et cetera, internationally. And so we conducted a lit review, but we noticed a major gap in the literature that, there are very few or no studies really high quality, sort of designed studies that allow you to measure the impact of changes or adaptations to primary care. And so we supplemented the literature review with interviews with experts and people who are studying this topic, but also providing care and making those practice level and system level changes to primary care to better serve this population. And so we conducted this study to sort of draw some lessons for what are promising models or features that we should think about. And we leveraged an analytical framework to really describe the types of interventions in terms of who, what, where, et cetera, but also to look at multiple dimensions of access to see how these features of primary care models impact the different availability, acceptability, quality of primary care. I'm going to summarize the top findings. We actually summarized the review results according to what we're calling six key considerations. And they're summarized here. The first three are listed on this slide. So the six key considerations really outline what the literature says we need to adapt primary care and innovate to better serve populations experiencing homelessness. The first was around relationships, and that this need for interpersonal relationships is fundamental. Surely this impacts not only care for people experiencing homelessness, but broadly patients with any care needs. The second consideration is around including many different types of providers in those interprofessional teams that already my colleagues have spoken about in terms of their importance. So it's not just doctors, nurses, and other allied professionals, but also people with lived experience or peer support workers. The literature suggests that this diversity of a workforce in primary care is really essential, especially in this vulnerable group. And the environment that is welcoming, inclusive, reducing barriers and stigma, and ensuring cultural and personal safety is vital, not only to ensure access to primary care, but also to foster connections with other social supports that are really integral to improving well-being and health. This slide shows the final three considerations that emerged from our research that were really critical to improving primary care. One is around the system supports, the supports around navigating and building connections to mainstream care, reducing barriers. So there's two parts to this. One is the critical role of primary care in navigating. And sometimes that involves actually personally and physically going with patients to appointments so that they're not stigmatized and not treated fairly or not provided care in those instances. And the second aspect there is around building connections. So oftentimes the primary care models are really serving as sort of outreach mobile clinics that are operating more on the margins of the primary care system. And there needs to be bridges back from those alternative models in non-traditional settings like pop-ups in shelters, for instance. They need to be bridged back to the mainstream primary care system where they can have attachment with a primary care team that can provide the high quality longitudinal relationship. The last 2 points relate to information sharing and funding sources, which were really critical as well. Because I'm trying to cover a lot of information, I'm going to move quickly and go into study 2 so that we have a chance to hear from everyone and get your comments and questions. The second study is it's a bit different, and we're looking at comparing the vaccination rollout, the COVID-19 vaccination rollout in 4 Canadian provinces. That, in Canada, there are 13 provinces and territories. Each one runs their own health system. And so this study looked at 4 provinces from different parts of the country to really understand, what some of the similarities and differences, and to draw some lessons in terms of what are some promising practices to overcome access barriers, improve vaccination uptake, and achieve those broad goals around, highest level of vaccination possible to manage the pandemic. And so the approach was really to undertake these rich case studies describing the process and the policies around the vaccination rollout in 4 provinces listed here on the slide. We modified a WHO framework that was created to look at the COVID-19 response across the European region that Canada, US, and Mexico also participated in, but we modified it to tailor to questions around provincial, territorial, and that's what I mean by PT here, vaccination campaigns. And so here are the different categories that we collected data from the literature and supplemented with expert review. We were focusing on the 2-dose vaccination series in the first year of the vaccination rollout. And a few key findings on, by some of these domains that we covered around, ensuring sufficient workforce capacity. There were different initiatives and approaches taken. All provinces imposed some mandatory vaccination for healthcare workers, except in Ontario, this was more limited to the long-term care sector. And then there were also public health orders and directions to allow other healthcare workers who didn't have previous authorization to administer vaccines to be able to do so during the COVID-19 pandemic, including pharmacists, naturopathic doctors, and others who traditionally had not been involved. And these sort of helped to show the types of resilience that was seen in enabling the rapid changes to existing models of care in the care delivery system and for vaccines to allow for the rapid uptake. The vaccination booking approaches was another lens that we took to compare across provinces, and we found variations in how centralized these systems were in terms of whether there was a single entry for the whole population to be able to book and register for their vaccines, or if there were multiple ways to access and book, and it was more, less coordinated. And so those variations really, shed some light on what some of the challenges were faced by the residents in those jurisdictions, especially among those outside of Nova Scotia and British Columbia, where there was a bit more of a centralized model, which is, increasing transparency, clarity, and convenience for the public. And additionally, we look to see how barriers to access might be overcome for some high-risk populations. And I've provided a few examples here of some of those promising strategies, although each province really took different approaches to reach rural and more remote populations, as well as those who had mobility problems and those who were experiencing homelessness, as well as recent immigrants who might not be familiar with navigating the health system. And so we've not been evaluating these, we're simply describing these at this point, trying to understand what are some of the efforts underway, but future work should really evaluate these. And I'm just going to end with the key takeaway in terms of the role of primary care providers in the vaccination rollout, which was extremely limited, and especially with primary care doctors, their role in mass vaccination, those major sort of vaccination sites that took place across the country, was really limited, except in British Columbia, where primary care doctors did take a leadership role in organizing and managing some of those mass vaccination clinics. However, in primary care offices, this was extremely limited to very few primary care offices, and often after significant advocacy by primary care professionals. On the flip side, the role of community pharmacies was significant across the country in terms of being a major source and site for receiving the COVID-19 vaccine. And so really to reflect and close, what these two illustrations and studies suggest is that there's huge potential to strengthen and improve primary care to better serve vulnerable populations, but also to support the health system's response to pandemic and resilience to future pandemics. Because what we've seen, at least in the vaccination rollout in Canada, in the 4 provinces and others that we've looked to, is that primary care has remained outside of that systems response, outside of the vaccination rollout, in part because of this unique and perhaps challenging Canada and in other jurisdictions where primary care providers remain independent practitioners that are not within a sort of managerial or hierarchical system. Levers cannot be pulled to mobilize primary care doctors as with other healthcare providers. So we are looking to see how different governance models with primary care networks and others may help to steer and to bring primary care more closely in the system to achieve broader health and public health goals. So I'll leave it at that, and I'm really happy again to have had this opportunity to share and participate today. Thank you very much.
Thank you, Professor Xiaolin, for your great presentation. I think I'm very interested in the vaccination strategy from healthcare system in Canada. I think there might be some interesting comparison between China's experiencing how the primary healthcare system perform in the vaccination process. Thank you again. Without further time consumption, it's over a little bit over, but all the 3 presenters have kept the time very, very, very nicely. Thank you. I will now hand over the chair's role to Professor Xiaolin Liu to chair the next three presentations and the final panel discussion. Professor Wei.
Thank you, Professor Liu. We just did a flip, so I'm going to introduce the speakers from China. And the first one would be Professor Roman Xu. So Professor Xu is a professor of global health in the China Southern Medical University. And he's also the leader of implementation science, the leader of using standard patient to measure the outcomes of the primary care. So I'm not going to repeat the topic of Professor Xu. So please, floor is yours. And another reminder that because we are overrun a little bit, so we just keep everybody within 10 minutes. Thank you.
Thank you, Professor Wei and Xiaoyun. I will share my screen. So thank you for the opportunity for me to share about our project of using standardized patient to create a random sample of cohort to track China's primary care quality, expenses, and patient experiences. So there are quite standardized patient is a sort of the fake patient, but they are trained in a standardized fashion and they will perform symptoms and the signs during their visit to clinicians. So when they were sent to visit primary care clinician without notifying the clinician, they can accurately connect information on quality of care, cost, expenses, and also patient experiences. So compared with the other method, when unannounced standardized patients are sent to visit clinicians, there is virtually very little or no hawthorne effect. And because of the standardization, they can also control the case mix. So we created this project in 2017 in the collaboration of more than 20 universities. We plan to measure the quality of primary healthcare using this method every 5 years. The study is called Acacia study. There is a very complicated sampling method. I'm not going into details of that, but in short, we have purposely selected 7 provinces from China. However, within those 7 provinces, we created a random sample of SP standardized patient visits so they can reflect very accurately by this representative sample of primary healthcare within those 7 provinces. Within our sample, we are planning to make 2,200 standardized patient visits, and there is a fair mix of private versus public institutions. And also we have defined primary healthcare in China as community healthcare centers, clinics, in the city health stations, but in the countryside, township health centers, and rural clinics, in addition to county hospitals. So which is a little different from the standardized definition of healthcare in China, because we have also added county hospital into the primary care level, in addition to the normal primary care definition here in China. We developed 13 cases, which are very commonly seen in the setting of primary health care. And we have also gone a big way in validating their accuracy and validity and reliability of those cases. I like to raise the point that all of those cases are sort of, we call textbook style cases. So they're really very simple cases without comorbidity, complication, very simple cases which should be easily handled by primary health care. And we have also designed those cases to cover different research objectives in a way, like something focus on prevention, some focus on treatment, etc., etc. Some on chronic conditions, some on infectious disease. So we aiming to have a fair good of coverage of the common conditions observed in the setting of primary health care. The pandemic has certainly created a big hurdle for our project because of the lockdown or close down of the primary care institutions or travel restrictions. However, over the past 2 years, we have been able to complete to this point, we have completed sort of 4/5 of the 2,200 cases all over China. Remember, this is a very challenging project because of the randomization of the sample. Sometimes for one single visit, because it's randomized, we may take 2 days to reach a very remote rural clinic for visit. So during the pandemic, it's a big challenge. We also face challenges in recruiting patients, train patients, in fielding, all those in raising funds. All those have come to the point we have faced a lot of complications we normally do not have without the pandemic. We have summarized our experiences of conducting this very large scale field work during the pandemic, and our recent work is published in the American Journal of Public Health. So if you are interested in how we actually implementing this project under the pandemic, I refer you to this paper. But in summary, we have taken up many of the innovations in using the technology to train the patient, to train and recruiting standardized the patient, and also using RedCap, which is an online system for data capturing, monitoring, and storage. And we heavily depending on that for quality control and the management of the field work. We also innovated to have one standardized patient to play two roles sometimes, so as to save cost and improve efficiency in building our work. So our protocol paper and our midterm result report, those two papers should give you a very good sense of how we do this project if you are interested in more details. But in summary, I'm a little reluctant to show this paper because our work is still ongoing. So this is a result focused on one domain on the technical quality of the results we have connected so far. So the work is ongoing. So this is sort of the midterm of the results of the data connection. And we have connected not only the technical quality of care, but also patient-centered care, expenses, and equity, and many other issues. But this slide focuses on the technical component of the primary health care quality. So if you can see, for the required by a clinical practice guideline, for the required consultation items, the primary care clinicians can only complete up to sort of the 20 or 25% of the required suggested items from the clinical practice guideline. And for the examinations, also the rates is also very low. They generally can complete only as low as 3%, 3.6% up to 20%, so very low. For the perfect diagnosis, it's also very low. Remember, the cases we have is very simple cases. And those low quality of care is not only for one province. If you can see, here are the 7 provinces we have a work going on. The quality actually do not vary substantially from province to province. So what this result says to us, because we expect Guangdong may have better provinces than Inner Mongolia, etc., but this is not happening. The quality is overall very poor. The quality is also does not really vary much from province to province. So this also pointed to the future research direction we are currently going to. One is we suspect the competency is very low, and that is probably one of the major reasons leading to the low quality of care. And our medical education probably is not playing a very good role, because even though some provinces have better trained clinicians, but the quality is not really that great. So either the healthcare system has the wrong incentives, or the competency which are obtained from the current medical education is not so good. So we are, in order to understand that, we are currently also using, with the support from the Ministry of Science and Technology, with a major project, to using smartphone-based virtual patient to assess the competency of the primary care clinicians. So with this virtual patient result and the standardized patient results, we can know precisely what is the no-do gap. So we know whether it is a problem of the competency, or it is a problem, the major problem is with the healthcare system incentives. Also, the virtual patient, we are also doing the randomized control study to see whether using virtual patient is a more effective way in training the, providing continuing medical education for primary care clinicians in that sense. The other thing is we found out traditional Chinese medicine, the patent medicine, has been extensively used in primary health care. And lots of them are very expensive. You can see from this screenshot. This is from 2 days ago. They recorded one case, the primary care clinicians are charging 2,000 Chinese money, which is almost $300 US for a traditional Chinese medicine in treating a very common condition, which in the case, they should not give this medicine at all. So we found out the use of traditional medicine and inappropriate use of traditional Chinese medicine, we assume that to be widespread. We are doing more careful analysis in this area, but we are also doing an experiment. We also put this in our this year's National Science Foundation application. If we get supported, we will do a randomized control study to see whether some intervention is effective in containing the inappropriate use of traditional Chinese medicine. So our case study is an open platform. Once the study is ended, once we have conducted our primary objective of data analysis, we will release the data for public use without any charge. And we are also very happy, despite our initial no founder interested in this project. To this point, we have raised about 2 million US funders in doing this project. Lots of funders have expressed their interest in supporting the initiative. So we are confident we are going to run this as a cohort and every 5 years. So thank you so much. We're also recruiting just an advertisement for students and postdoc in doing this project if you are interested. Thank you.
Thank you very much, Dr. Xu. That is really a promising study, and you have implemented so many, I would say, well-designed methodologies. Thanks. So the next speaker will be Professor Wenhua Wang. Professor Wenhua Wang is an associate professor from the Xi'an Jiaotong University, and he also used to study in McGill University. So he's quite familiar with Canada as well. His topic is going to be the high quality primary healthcare from public perspective in China. Wenhua, please.
Okay, thank you very much, Professor Wei. And thank you for giving me this opportunity to share one of my recent studies. Today, I want to share with you about a recent study to explore public expectation of high-quality primary healthcare in China. So, why we want to conduct this study? There are several points. First is, during the past 10 years, China has invested huge money and resources in primary care. And this huge investment has translated into primary care capacity building. The figure 1 shows the number of big medical equipment and the number of primary care workforce increased a lot during the past 10 years. Ideally, this resource increase should translate into expansion of service provision. Yes, and in absolute number of service provision in primary care, it increased during the past 10 years. However, our further analysis shows in figure 2, the share or the proportion of outpatient visit by primary care organizations in the whole China system is decreasing. It decreased from 62% in 2010 and to nearly 50% in 2019. So we are very curious about why in one side the capacity is increasing, and in the other side the proportion of service provision in primary care is decreasing sharply. And through literature review, we found the low quality of care in primary care is a main driver of this phenomenon. And based on our literature review, we found there are 3 aspects about low quality in primary care. The first, in primary care, the provider has a very low adherence to clinical standards or clinical professional guidelines based on some simulated patient study. And the second point is the inappropriate prescribing behavior is very severe, especially the overuse of antibiotics in primary care settings in China. And the third point is the low or negative patient experience, especially about the service attitude during the patient and the clinician encounter. So with these questions, China currently reorienting the delivery system to build people-centered integrated care. So the first point to build this PCIC model is we should have clear knowledge of what high-quality primary care look like from the public perspective. So with this question, we did the following study. In this study, is mainly a quantitative study design. And in China, we select 6 provinces. In each province, we select the capital city. And based on the sample size requirement for this type of study, we initially recruit 8 to 12 participant community residents in each capital city. So finally, about 58 participants completed our interview. And the following result is based on thematic analysis among the prescription data from these 58 participants. So in this study, there are three main questions. First, what would primary care service look like from the public perspective? The second is, what would primary care doctor look like from the patient's opinion? The last one, the third one, is what a good primary care organization look like. So this picture is the first part about the good primary care services profile from the public perspective. Our initial code framework is based on Starfield and the World Bank Primary Healthcare Performance Initiative framework. And finally, there are 7 domains emerged from our data in China. And this 7 domain is reported and represented by the rank of importance. For example, for Chinese public, they have very strong expectation for interpersonal communication, which means the doctor should listen carefully, and the patient could ask questions they cannot understand, and this is interpersonal communication. And the other very strong expectation is for technical quality, which means the doctor should give accurate diagnosis and a very effective treatment plan. And we also know in other countries, people also have common expectations for these 2 aspects. However, there are several special differences among Chinese public. For example, for the interpersonal communication among Chinese residents, they have very, very strong expectation for the friendly and the patient service attitude during the clinical encounter, which is not the case in other countries. And for technical quality, the China special feature is the Chinese public have strong expectation for the appropriate use of medical examination and appropriate use of medicine. This is another differences with other countries. And besides these 2 points, the Chinese public also have moderate expectation for access, comprehensiveness, and continuity and cost. These 4 domains, about 50 to 70% of the participants show their strong preference for these 4 domains. And the last one for coordination, the Chinese public only have very, very less expectation for this domain. It is probably because the current China delivery system is also fragmented, and maybe in the next stage, when the integrated care model can be built, the public may increase their expectation for this domain. This is the 7 domains from Chinese public, the profile of good primary care services. And for the second part, the profile of good primary care doctors among Chinese people, there are three domains emerged. The initial code framework is based on the Canadian Family Medicine Competency Framework in 2017. And these 3 domains, the first one is about the personal characteristic of the primary care doctor. The Chinese people hope the good doctor should receive well education, and they should have an older age. And this 2 points is very important for the Chinese public. And the second important point is the medical expertise. And all the participants show their strong expectation for primary care doctors. And in this domain, there are 4 elements. The first one is the scope of practice. The Chinese people hope the good primary care doctor should provide both primary medical care, basic medical care, and public health service, and also health guidance and management. And the second element is clinical experience. The Chinese people hope the good primary care doctor should be senior, old age, and with very rich clinical experience. And also the last 2 is about clinical qualification. One is they hope the good doctor should have strong diagnostic and therapeutic clinical ability, and also they should have received the legal medical qualification, like in China, the National Physician License Examination. They should pass this examination. This is the second domain of good primary care doctor. The last one is similar to the good primary care services. The Chinese public also hope the good primary care doctor should have very strong interpersonal skills. They should play a very important role in information collection and also should give clear explanation. This is the three domains of good primary care doctor from the Chinese public's opinion. And the last one about the good primary care organization. The initial code framework is based on CIHR, the organization of primary care framework. It published, I think, about 5 years ago by some researchers in Quebec and Ontario. It's a joint team. And based on this framework, we explore the Chinese public's expectation for the good primary care organization. Finally, 4 domains emerged. The first one is also about the basic characteristic of the organization. The Chinese people hope the good primary care organization should be near their home and should have very clean environment, and it's better be owned and management by the government. This is the three elements of basic characteristics. The second one is about organization resources. The Chinese people strongly mentioned a good primary care organization should have enough qualified family physicians, and also they should have very good health information system, which they can own a medical card, and with this card, all the information can be collected and in the system, not only in the primary care organization, but also can be then check the information in the hospital. This is the 2 elements of good the organization resources. And the third one is about organization structure. In this domain, only one element emerged, is about the quality improvement structure. About 1/3 of the participants hope the good primary care organization should have some specific unit or organization or department to promote the quality and to improve the treatment outcome and patient experience or satisfaction. The last one and the fourth one is about the service provision and the clinical practice. And in this domain, there are also 4 elements. The first one is about the good primary care organization should provide high quality care. This high quality not only include the clinical or technical quality, but also positive patient experience. And the second element is about the degree of integration. It includes 2 points. The first one is the internal integration. The different departments, they should establish the smooth collaboration, and the workflow should be very smooth and convenient for the patient. The second point in this element is about outside integration. It means the good primary care organization should establish a very close collaboration with the hospital system, which is based on the referral system. That's the expectation of the Chinese resident. And the third one is about the scope and the category of services. The public hope the good primary care organization should provide medical care and public health and health management, and all these services should be provided in the primary care setting. And the last one is about 1/3 of the participants hope the cost should be lower, should be affordable in the primary care setting. This point is also unique in China. It's mainly because of the social insurance model. So this is the good primary care organization from the Chinese public expectation. And we also did some literature review. We want to know what the public expect or hope is associated with the quality of care. And we found some of the features valued by the public. Yes, it has close link with the good quality of care. However, some of the features, especially at the physician level and at the organization level, is not associated with the high clinical quality or positive patient experience. So next, we will explore more features at the physician level and the organization level to know in China primary care setting, which features of primary care organization, which features of primary care physician in China could provide good quality of care. And based on this qualitative study and our preliminary literature review, we propose these three recommendations. First, for the service, China should develop a context-based national primary healthcare quality management instrument. I know the World Bank Primary Healthcare Performance Initiative may be a good example for us to learn. And the second one, to train qualified and motivated physicians. First, China should develop the China Family Physician Competency Framework, which could guide the family physician training and on-the-job training. And the second one is about support a local primary care organization to build a learning organization. And the last one, we should also pay attention to the motivation, the software, like organization commitment, professional fulfillment, this aspect of primary care physician. And the last recommendation at the organization level, there are 3 points. First point, we should transform the current department service structure to a team of people structure. Because currently in primary care organization in China, the service provision is organized around the department and the performance target is the quantity of service. However, China is also building the family team model. Next, is possible we should organize the service around the family doctor team, and the performance target should be focused on people's experience and health outcome. The second point is it's very difficult to connect hospital and primary care organizations initially, but it's much easier to connect family doctor team and specialist team in hospital. Maybe the starting point should be at the team level, the integration, and not organization level. And the last one, we should also develop a blended payment model, because currently there are several financial resources, including government subsidy and social insurance input, and also out-of-pocket payment. Next, maybe we can organize this money together, and based on the team of people model, we should develop an appropriate context-based payment model. And this is all the knowledge I want to share today. And thank you, Professor Wei. Thank you for your listening.
Thank you, Wenhua. We are really running into a very tight schedule right now. So there's only 10 minutes left. So the next speaker will be Professor Beibei Yuan from Peking University. So her topic is going to be integration of the basic public health services and medical services in China's primary health care system. So I want to see Professor Yuan, can you just shorten it to be within 10 minutes? We can just overrun for 5 minutes for the questions.
Okay. Thank you, Professor Wei. I will try my best to finish it in 10 minutes. And no, it is a great challenge for me. I'm very happy to discuss the PHC system in China with you today. And the topic I will discuss today is about the integration of care in primary health system. I'm very happy that Professor Xu and Professor Wang also mentioned some background on the primary health care in China. It's both of them mentioned the challenge of the integration problem in the primary health system. I will introduce the following 3 parts. And I think that most of you have some basic knowledge or on the China health system. And these figures just want to show the background that what is the primary health system in China. Usually in practice, the primary health policies mainly targeting the primary health providers which include the township health centers, village clinics in rural area, and the community health centers and the community health stations in urban area. And these figures, the structures also show some background on why China primary health system usually have problem of integration of public and medical services, because above the grassroots level, there is two separate system, public health system and medical system. They work independently and give the independent direction and the supervision on primary health system. And the primary health care in China include both basic public health services and basic medical services provided by the primary health facility. Basic public health services delivered by the primary health facilities were defined by the equalization of basic public health service policy, in which there is a basic public health service package, which is defined as a task of public health facilities and fully financed by government subsidy. This package started from 9 categories in 2008 and have expanded to 14 categories by 2017. And this figure shows the item of the basic public health services in this package. And I will show one example in the following slides. And the basic medical services means diagnosis and treatment for common disease and frequently occurring disease. There are no clear package for this service in policy document, but we can find some relevant items from government policy on evaluation of service capacity for township health centers. Based on the capacity of medical service or primary health facility, primary health facility can be rated at C level, the lowest level, which means that at least 50 kinds of outpatient disease they treated. And all the highest level is A3, with more than 10 kinds of common disease in outpatient care, more than 16 kinds of disease in inpatient care, and more than 10 kinds of surgery operation disease. We can use one example to show the specific items defined by this two package, which is for the diabetes care. We can see that in the basic public health package, the items including the screening, the face-to-face follow-up 4 times per year, and a comprehensive health examination per year. In the basic medical service, it's generally broadly defined as identification and diagnosis of diabetes. There is a guideline for the diabetes diagnosis and treatment for the primary health providers in China, but actually there is no mechanism or measures to push the health providers in primary health care facilities to implement this guideline. We can see that actually there are overlap between the service among these two kinds of the package, but in practice, the primary health provider usually treats them separately. I will describe it in the following slide. And the next part is the challenging service delivery. It means that how the primary health providers deliver this two kind of package in practice. And this part, the data is based on the evidence, data from cross-sectional survey data from 6 cities conducted in 2019, sorry, it's 19, not 2009. And all the reference, the data some are published, some are on the review, and this is our references, but I organized them in different kind of format in this slide. And the first challenge is in the levels of individual health providers. We first look at how each individual health workers treated two kinds of services. We investigate the doctors and nurses in primary health services, primary health facilities. We found that they treated and could differentiate two kinds of services very clearly. And the doctor used 33% working time, and the nurses used 46% working time on the basic public health service package related tasks. If we measured from the perspective of diabetes patients, it was found that 37% of them receive education and other follow-up communication service defined by the basic public health service package in outpatient consultation. It means that for most of the patients, they just get prescription or instruction on medicine use in outpatient process. Even in this process, doctors can integrate other follow-up services into it. They didn't do that because of some other reasons I will explain. And we also use the some self-development skills to measure the perception of doctors and nurses on two kinds of service package. It was shown that in their opinion, about 58% of the health professionals rated the curative services as more important than preventive services in all of their work responsibilities. And we also analyzed how the team level work together for two kinds of services. We found that all the primary health facilities organized their department in traditional way. And it means that the clinical department being charged of outpatient and inpatient services, and a separate independent public health department being charged of public health tasks. That is, we have explained in the background of the overall delivery structure. They need to accountable to different supervision departments. Usually the public health department need medical doctor or nurses using their extra time in cooperating specific public health tasks. Family doctor teams, it's a policy starting from the 2017. It's a kind of a multidisciplinary team across all departments have been established when we did these investigations. And they use this method to better cooperation or chronic disease management. But it was at a beginning stage. The primary health workers rated the coordination level as 2.8 score, with 4 being the highest score. And the system level support factors for integration were also analyzed. It was found that the 63% of investigated facilities finished the integration with electronic prescription system and the health document system. It means that in 37% of facilities, doctors cannot check and update the health document to do the follow-up services when they saw a diabetes patient in outpatient. If we look at a performance-based salary system, about 90% of investigated facilities, the income of health professionals were more dependent on volume of clinical outpatient and inpatient services. As we mentioned, the public health department usually need to use doctors' extra time in public health package. On the current payment system, this kind of payment system, they usually did that on the administrative pressure without motivation to do that better. Furthermore, as we mentioned, the service package for two kinds of services were designed and issued by different supervision departments. There is no guideline issued to help primary health facility to integrate the procedures of two kinds of services, even there are overlaps. Lastly, but it also the fundamental reason, it's the financing system of primary health facilities. It didn't support the integration of the two kinds of services. As this figure shows, and there is two major revenue sources for the primary health facilities. The financing system the government fund pay the primary health facilities for the basic public health package based on the fixed budget per capita criteria. And usually the government have a limited space to increase the fund because of the government revenues increase slow down and the local government limit capacities in increasing revenue. At the same time, the medical insurance fund pay the out and inpatient services. It's only covered the treatment and medicine, no coverage of education and follow-up care. And the payment usually is the fee-for-service with a global budget ceiling, which still have incentives for the primary health facilities to deliver more medical services for more income. So this means that there are conflicts in the direction of incentive of these two revenue sources. The health administration department link the payment of the basic public health fund with the performance in preventive services and create pressure on primary health facilities to provide this kind of preventive and management care. While the insurance fund created the incentive to over-prescribe and less attention to preventive care. So there are the conflict in the direction of incentive. So we can, lastly, the poor quality of chronic disease management care could also reflect the need for better organization and integration of service in primary health facility. With the diabetes and example, we found that if we use blood glucose control could reflect the quality of services. The data show that the control rate remains persistently, and the survey data show the much lower than the administration data. We also use our survey data to analyze the correlation between some integration factors with the performance of diabetes care in control of the blood glucose. And this table shows that the two integration factors, support factors. One is the integration of medical system and electronic health document, and the payment related to performance on public health services. They are both related to more proportion of the patient with blood glucose controlled. And lastly, I will introduce some, very briefly, some current efforts, national or local level efforts to integrate the public health services and medical services to promote the first one is the family doctor team policies. It started from 2017. And this figure shows the organization. They use some multi-discipline team to work together to push to organize the doctors and primary health worker together to better integrate the services. And in these policies, it's encouraged the local government or the local facilities to reorganize the contracted family doctor service package to reorganize the basic public health services and the medical services together. So this is a chance to better integrate them. And in some area, like in Beijing, some community health centers in Beijing, they reorganized their internal department to better integrate services. So they built the new department, chronic disease department, but not traditional the clinical and the public department. They to better integrate service for chronic disease. Another major reform trend is about the build of the county level medical alliance. There are many, these policies just aims to use the leverage of the hospital to improve the capacity of the local primary health facility. In these policies, there are several measures which can contribute to integrate of the public and the medical services in primary health facility. For example, there are two major measures. One is a support, technical support. Usually, in some area, the medical alliance will let the medical specialist from hospital and some public health professionals to join the medical doctor team to help better organize the services in primary level. And another very crucial reform is payment reform. It started to use the bundle payment with to the whole medical lines based on the need of the whole region's whole residents' health needs, and with the sharing saving. So it creates incentive for the lead hospital to better develop the preventive health services in primary health level. And it's also measures to push to better integrate preventive healthcare in their routine medical services. One typical area is Shenzhen Luohu district. And another way is to improve the service procedures. Actually, these two models are comprehensive. They also use some others measures I mentioned in the last slides. Like the Xiamen 三师共管的, it means that 3 integrate management by 3 kind of health professionals and the Shanghai hospital community integration model. It's just for this kind of the models, they use some reorganization of service procedures and also allocate the service task and the procedures to different kind of health professionals clearly, to make the all the procedures more integrate and continually. So that's all my introduction. Thank you very much.
Thank you, Professor Yuan. And I know it's very hard to finish the presentation within 10 minutes for each one. And I could, Professor Yuan, could you unshare your slides?
Okay.
Thank you. I know the time has been passing by, so right now it's 5 minutes overdue. Would it be possible we can just allow one burning question? I noticed there has been lots of good discussions among the presenters and also between students and professors. I just want to say that who would want to ask a burning question at this moment? Maybe we can give that chance to Quan.
Oh, hello. Really interesting talk. I just have a question because I'm not in primary care. Just out of curiosity, to Professor Yuan's wonderful presentation, it seems like the healthcare network is hierarchical. So you have hospital level, and then it goes down to county level. So in this kind of complex structure, how would you assess policy effectiveness? Like what are the sort of indicators? How would you make sure what the network is set up to do has achieved its goals? Because I'm from a Cisco background, so I'm thinking, in terms of comparing policy, we would sometimes do quasi-experimental design, or we change one factor of the network and assess how that the effectiveness of that one element. But in a complex structure, how would that be assessed?
Sorry, could I ask what do you mean about it's about the performance indicator, or what do you mean about the?
Right. So I think you mentioned 2 examples. Like there's 1-3 management combination. I just wanted to be brief. Sorry, I don't want to take too much time. So there's 3 professions kind of network in the Xiamen, if I remember it correctly. So how would you assess how that framework is successful comparing to regions that didn't implement that 3 kind of professional interconnected management?
Okay. So I think it's difficult. I think if we assess how these Xiamen's models work or not, it should measure it in the team unit. It's if I understand your question in the right way, and because there are some because they use some mechanism to, for example, they use some financial incentive to encourage the medical specialist in the hospital or the health management specialist to input in the family doctor team. So if we want to measure how these models work, I think it's just measured in the team level, team unit. Sorry, if, I don't know if I understand your question in the right way.
That's a great answer. So I was thinking, like at the team level, if you do another survey, it could look at if there's improved coordination, like people rate that they have saved time, like resources being conserved, and yeah, thank you. I think you definitely answered it.
Okay, thank you, Ken. And I think that is not an easy question because you need to deep dive into the context. I can say that there had been so many amazing topics we have addressed in different settings. For example, like the overall framework, how to measure quality care from the World Bank perspective, and also how to incorporate innovations and incorporate the integration of public health and clinical care into this. First, I think I would thank all the speakers for the excellent presentation within such a short time, and all the topics were kind of cutting edge on the right now development of the, for example, COVID pandemic and in this difficult time, how care quality. And also I would mention that there are large knowledge which would from participate into this talk. For example, like there's a Department of Family and Community Medicine here, which is focused on the primary care and mostly are primary care physicians. And also, I'm very happy to see that we get involvement, very deep involvement from the faculties here and from the students as well. So I hope that in the future, we could establish a very strong institution-to-institution connection and then promote the collaboration between us. So lastly, I would like to thank Professor Meng and Professor Laporte, and also I want to mention as Nini, our dean, Adelstein Brown. Professor Brown is also very supportive to this workshop. I would want to see Xiaoyun, do you have any final words?
No, thank you very much. All the wonderful presentation. I think this is a successful workshop. Unless if we have more time for discussion, I hope for the next event. Thank you.
Okay, thank you very much. We would have all the contacts ready and have this recorded. Thank you.